Thanks, Dr. Gleason, for having me. Today, we'll talk about focal therapy, and before I begin, I'd just like to disclose I am an interventional radiologist as well. The objectives today, we're going to go over image-guided therapy. We'll discuss index lesion theory and prostate cancer, go over focal therapy, and discuss some of the ablative techniques that can be used for focal therapy. Review imaging of prostate cancer, specifically with relations to MR, and then just talk about some future directions briefly. Before we begin, just what is image-guided surgery? Well, it's treating disease without a scalpel. We see its use throughout our surgical specialties, from neurosurgery to hepatobiliary, and in urology, probably the biggest player for this was actually with stone disease with extracorporeal shockwave lithotripsy. And with renal cell carcinoma, with small renal masses, renal ablation is actually becoming, over the past 10 to 15 years, it's become a valid treatment option for select patients. Well, at UCLA, I worked with the radiologists, obviously, and we looked at predictors for efficacy with regards to renal ablation, trying to see if there's ways we can predict what patients could be treated efficaciously with a single treatment compared to needing more than one treatment. And what we showed was, what previous studies have demonstrated, was that lesion size, so tumors less than 3 centimeters, are more likely to be treated in a single session. Location of the tumor matters with treatment efficacy. And then we also showed that pathology may impact outcomes with regards to how efficacious we are with renal ablation. And to me, that suggests that it's really important to biopsy every lesion when trying to decide whether we do surveillance, ablation, or surgery. And I also think that ablative techniques are where the future may hold for prostate cancer. So prostate cancer, we all know prostate cancer. We all know the good, the bad, and the ugly. This is a great study from Eggener, and basically they looked at about 10,000 patients who underwent radical prostatectomy and then looked at the overall and prostate cancer-specific mortality. And what you can see here is that at 20 years, the prostate cancer-specific mortality is as demonstrated. I don't think there's a pointer here. Well, that thin black line on the top there is the mortality, and that's 1.2%. And when you compare, pardon? There we go. Oh, I see. Okay. So right here, I'm screwing it up. So I'll do it here. So, and then with the Gleason Score 8, you see that the mortality is much higher, about 32%. So this is why the whole idea of active surveillance started, in the sense that we're treating patients too much. So we're treating patients with low-risk cancer, who are the majority of patients who present, and we're causing them the morbidity of surgery and radiation therapy, which includes incontinence and impotence. And so groups from Toronto and Johns Hopkins really revolutionized managing prostate cancer with the concept of active surveillance in a subset of patients. And numerous studies have demonstrated that active surveillance works. This is an excellent review looking at numerous groups that have used active surveillance in treating prostate cancer. And what they show is a similar prostate cancer-specific mortality in these patients with less than 1.5%, about 5 years. The problem with active surveillance is people fail. So at 5 years, anywhere from 20 to 40% progress. So the Gleason score gets concerning, or the PSA rises. So that risk stratification that we were using to put patients on active surveillance changes, and they no longer are considered to be safe to survey. And that's where I think focal therapy may play a role and help changing that risk stratification if you can target that specific lesion. But before beginning about focal therapy, we've got to talk about prostate cancer and what it looks like. So focal therapy is the concept of using a ablative technique to, I'm not going to mess with the mouse, I'll just mess it up. So as demonstrated on the right there, you either use an ablative therapy, whether it be HIFU, ablation, IRE, and kill the prostate, but save the periprostatic tissues, and hopefully preserving the neurovascular bundle, so improving erectile function, and then decreasing the risk of incontinence. The problem is the majority of prostate cancers is shown in slide A on that pathology specimen. That's unifocal disease, and that only occurs about 10 to 15% of the time. So most men with prostate cancer have multifocal disease. So how do you treat a multifocal disease with a focal ablative therapy? Ward and Anderson investigated that by looking at patients who underwent a radical prostatectomy, and they looked at the cohort that was presumed to be unifocal based on pre-biopsy. And what they found is if they did a hemiablative technique and looked at the final pathology, they found that they would have only treated about 17% of the patients with a hemiablation as shown in that slide A. Now, if they did a hockey stick ablation, where you include that one side of the prostate and do the anterior zone, or that hockey stick approach, then you treat 47% of all prostate cancer foci. However, if you delineated significant prostate cancer versus non-significant prostate cancer, where significant prostate cancer would be Gleason score greater than 7, or greater than or equal to 7, prostate cancer volume greater than half a cc, then the hemiablative technique increased to 67% of treating significant prostate cancer. And when you do the hockey stick approach, you treat 87%. So the thought was with focal therapy could be potentially useful when you look for the index lesion or the focus of highest prostate cancer grade or size. And that's where this index lesion hypothesis stemmed from. And it's the thought that the largest lesion tends to have the highest Gleason score. And that's the one that dictates the prognosis and overall biology of the cancer. Whereas these smaller foci of Gleason 6 or presumed Gleason 6 prostate cancers are indolent and won't cause any problems with overall patient disease pathology. When looking at this, this is from Dr. Ahmed, and they looked at 100 patients who underwent radical prostatectomy and then looked at the whole gland histopathology. And as we see, unifocal disease was only seen in about 22% of the patients. So again, the minority of patients have unifocal disease. And then when looking at the index lesion, as defined as the focus of cancer with the highest Gleason score, or the largest lesion if the Gleason score was Gleason 6, they found that volume, overall stage, that was predominantly predicted by the index lesion. In fact, when you look at secondary lesions, so the non-index lesion, the 99% of those patients, or those lesions, were Gleason score 6 or less, and only 2 of those cases, or 1%, had extracapsular extension. So this is just one example of perhaps the index lesion may be not just a theory. And this is another study from Wise, and this is at Stanford. This is about 500 patients who underwent radical prostatectomy. And what they looked at was the index lesion in unifocal disease is demonstrated by the white bar, and then the largest lesion or index lesion in multifocal disease as shown in the black bar. And when looking at biochemical failure, you can see as the lesion increases in size, whether it's the index or with multifocal disease, then the biochemical failure increases. So this suggests that lesion size or the index lesion may predict the biology of the disease. And then I show the graph there on the right, just demonstrating the importance of Gleason grade 4 and 5, predicting the biochemical failure rate with regards to prostate cancer. Another potential proof of concept, if you will, of the index lesion is the monoclonal origin of metastatic disease. And this was a group of Dr. Liu, and he looked at I think 30 patients with 93 metastatic lesions, and then they looked at single nucleotide polymorphisms to try to determine if all the metastatic lesions were from a precursor. And what they were able to do was show that the metastatic lesions all did come from a presumed single origin of prostate cancer. So all those studies looking at the index lesion compared or used a whole pathology mount to assess the outcome of that. So they had a prostate gland in their hands, and that's not really focal therapy because we want to keep the prostate gland there. So how can we see that index lesion from an imaging perspective? And that's where MRI comes into play. MRI is great. It looks at both anatomic and functional aspects of the prostate. And the standard multi-parametric MRI will include T1 weighted imaging to look for hemorrhage. It'll look at T2 imaging to look for the location of the tumor, and it allows you to assess for extracapsular extension. And then you look at restricted diffusion in the ADC map, and then you can also use dynamic contrast imaging. And then there's some, it's not used as much now, but historically spectroscopy was also used. And then PI-RADS, I think, is critical when working with prostate MRI because it's a standardized report of prostate cancer imaging. And basically what it does is it grades a lesion seen on MRI from a grade 1 to 5, where 1 is low risk of prostate cancer, 3 is high risk of likelihood of prostate cancer, and 3 is our radiologist kind of hedge, which is necessary at times. When looking at prostate cancer localization with MRI, I work with Dr. Reiter at trying to see how useful prostate MRI was in predicting the need to do nerve-sparing prostatectomy with robotic prostatectomies, and we found a sensitivity of about 50% and a specificity of 97% when looking at the staging of prostate cancer. Since that, there's been numerous studies that have looked at the overall specificity and sensitivity of prostate MR. This was a great review that looked at 38 studies, which included about 4,000 patients. And you can see the ROC curve on the right. And what you can see is sensitivity, which is here. It varies more. It varies basically when you change the multi-parametric. So as you add T2, DWI, DCE, overall sensitivity tends to increase. And then the specificity is actually pretty, doesn't fluctuate as much when it comes to this. When specifically looking at extracapsular extension or seminal vesicle invasion, you can see the ROC curves there, and the sensitivity for looking at extracapsular extension with this same review, just specifically looking at these two pathologic stages, was 57%, specificity was 91%, and then when looking at seminal vesicle invasion or T3B disease, the sensitivity was about 58%, and the sensitivity was 98%. Just a quick.
Can I ask a question?
Yeah.
Is that, how does that account for whether or not you had a recent file?
So these were all based on pathology or like histologic pathology. Is that what you're asking?
Well, I was just saying, if you had a biopsy prior to the MRI, how does that confound the specificity?
I don't think that was looked at, but usually you'll look at the T1 imaging before to see if there's hemorrhage, and then there's ways that we as radiologists would determine whether or not that's confounding. And usually biopsy before MRI, as long as you wait about 6 to 8 weeks, it doesn't cause a problem. That's why you want that T1 imaging to make sure that there's no hemorrhage there to kind of give a false positive, so to speak. And just to put in context, the mammography has a specificity of about 90 to 95%, and sensitivity is about 75 to 90%. So there's room for improvement. When looking, and this slide just demonstrates that as you increase those multi-parametrics, so starting with T2, then adding DWI, DCE, the area under the curve increases. And the slide on the right just showing the nodes, and it also shows when looking for nodal disease that when you add these parametrics, the area under the curve increases as well. So basically, as we add different sequences to the MR, we improve the accuracy of diagnosing cancer. And this is just a good example of showing the PI-RADS. Again, PI-RADS 1 being low risk for prostate cancer, PI-RADS 5 being a high suspicion. And as you can see, with PI-RADS 1, the sensitivity is about 88%, and the accuracy or negative predictive value is about 2%, and then with PI-RADS 5, I'll close that. You'd think I'd be more computer savvy given I'm a radiologist, but I guess not. And basically the accuracy improves as with PI-RADS 5. And this is just showing the area under a curve, looking at PI-RADS in determining prostate cancer. And again, it's about 89% when used appropriately. Emerging techniques are coming into imaging. This is a technique called restriction spectrum imaging. It was originally used in brain imaging, and basically this was a study that looked at 27 patients who had imaging with RSI in addition to the standard multi-parametric MRI, which included T2, T1, DCE, and DWI-ADC. And of those 27 patients, 9 had extracapsular extension. When using the standard MRI in this cohort, they were able to identify the extracapsular extension 22% of the time. However, when you added this RSI, the accuracy increased to 89%. So I think the future of imaging for prostate cancer, a lot of it will be new techniques, new ways to kind of help characterize these lesions that we see on MR. And then what about the lesions that we do see on MR? Are they different? This is a study from NYU, and what they looked at was they looked at about 49 patients, looked at the pre-op MRI, and then a post-operative histopathology, and what they found was lesions that you see on MRI tend to be larger, tend to have a Gleason score greater than 7, and then have a solid tumor growth pattern. So essentially, we may be identifying lesions on MR that are clinically significant, and then we're missing those indolent Gleason 6 cancers. This was a study from UCLA that looked at multi-parametric MRI and specifically looking at the index lesion. And what this does nicely is shows that as you increase the size of the tumor, you increase the ability to detect the prostate cancer. When looking at Gleason score, as you increase the Gleason grade, so too do you increase the likelihood of seeing it. In fact, about 79% of Gleason 6 is missed with prostate multi-parametric MRI. And then when looking at the index tumor, I think this is key to note because this is a limitation of prostate MRI, is that you pick up about 80% of the index lesions, but you miss 20%. So we're not there yet with finding all these index lesions on MRI. So focal therapy, we just briefly touched upon the whole concept of how focal therapy could work, particularly if you're treating the significant cancer and ignoring the secondary lesions. We talked about the index lesion theory, and then we also discussed the multi-parametrics MRI and its use and accuracy in seeing prostate cancer, so to speak. What about focal therapy? So this is where we'll discuss the ablative techniques. Now, there's many ways to treat prostate cancer. You can do laser ablation, you can do HIFU, you can do RFA, you can do cryo, you can do IRE, focal brachytherapy. It's all over the place. The majority of studies thus far have been on cryoablation and HIFU. If you look at the ongoing clinical trials right now, there's about 14, the majority of which are actually laser ablation. Ultimately, I think what we do will probably depend on what resources we have available, and we'll just work with that and become experts in that. It's similar to renal ablation. So if you talk to different centers, some centers will only do cryoablation, some will do both, some will do microwave. It all depends on the expertise of the individual doing it. So I think what ablative technology we'll use will depend on what resources are available and what the treating physician feels comfortable doing. That being said, there's 2 studies I'd like to highlight. One is more of a review from Dr. Ahmed, and what he looked at was he looked at all the studies that have looked at focal therapy, and he found 25 in total, and they identified about 2,000 men who were treated primarily for focal therapy, so this isn't salvage therapy or anything like that. Of patients treated primarily, the majority were low risk. 56% of those patients were low risk. 36% were intermediate, and 8% were high. And the majority of patients had Gleason Score 6. Localization of the prostate cancer for these patients, the majority of it was done with truss biopsy and or transperineal template biopsy, and the majority of them used MRI to help identify those lesions that were treated. And it's important to note for the studies that were reviewed here, all the cancer foci was treated. So this was not a treatment where you just treated the one index lesion. They treated all areas of prostate cancer. And what they found was follow-up is okay. 13 of 25, so a little bit over half of the studies had mean follow-up at 3.4 years. Outcomes, side effect profile was okay. Retention, UTIs 0 to 17%, strictures 0 to 5%, pad-free continence and no erectile dysfunction ranged from, for pad-free incontinence, 95 to 100%, and erectile function ranged from 50 to 100%. And then looking specifically at oncologic outcomes, which is what we're most interested about, the absence of clinically significant cancer on repeat biopsy ranged anywhere from 83 to 100%. And then if you broke that down to absence of any cancer at all, then that range varied from 77 to 96%. When looking at biochemical recurrence-free survival, that ranged in years follow-up from 1 to 8, I believe, and the range varied from 38 to 93%. But defining biochemical recurrence in focal therapy is hard to do because you're not treating the entire gland. And then only 3 studies looked at prostate cancer-specific mortality greater than 5 years, and for those three studies, it was 0%. What I found most interesting was a recent paper that Dr. Ahmed did from University College London, and that was where they actually treated just the index lesion. So they ignored clinically insignificant cancer, which was defined as Gleason score less than 6, or if it was a Gleason score 6, it was the smallest lesion. So they basically treated the highest grade lesion or the largest tumor. They treated 56 men. This was a prospective study. Mean age of the man was 64, PSA was 7.4, and the majority of these patients were actually intermediate risk. So these are patients that I think might have been patients that could have been on active surveillance. They've moved on to intermediate risk, and then so this is the patient population I think really may benefit from focal therapy. And then complication profile, there are some issues. There's about 4% risk of strictures, so strictures an issue. Hematuria, UTIs, and dysuria. What they nicely show here is, I actually think, the limitations of focal therapy as to where it stands now. Because if you look at the pad-free and leak-free continence, as demonstrated by the green and the blue line, it's 92%. Erectile function is only 77% at 1 year. And that's not better than surgery. I think surgery, when you talk to surgeons, they'll say their pad-free incontinence is better. Issues with erections is better than that. And then it also shows that the trifecta, which is what you'd aim to achieve, which is cancer-free, continent, and have no issues with erectile dysfunction, that was only 53%. So there's a lot of room for improvement with this. And then I touched on it briefly with regards to defining success in the biochemical recurrence. So how do you monitor these patients who've been biopsied? Is there a way to do this? And there's really no standard definition that's been approached right now. What you need to include, at least the minimum, is biopsy showing that there's no recurrence, and you need imaging to show that there's no recurrence, and then also you'd like to have some ability to follow this from a biochemical perspective. Most studies now will report on the Phoenix and Astro criteria, but as we all know, that was for XRT, and that's whole gland therapy. That's not partial gland therapy. Sugart came up with an idea or a concept of defining biochemical failure based on HIFU, but again, that was whole gland HIFU ablation, and when his criteria is basically the nadir plus 1.2, but he showed that for the majority of patients, the nadir was less than 1. And in that previous study that I showed with Dr. Ahmed, where they just did that focal lesion ablation, the PSA with the mean at 12 months was 2.4, so I'm not sure that's a good criteria for that either. So there's no real current consensus on what PSA kinetics should be, or how they should be used to monitor disease progression with focal therapy. So limitations to this, obviously index lesion is just a theory so far. I mean, it's just looking at whole glands. There's no data that look at the long-term outcomes of just treating the index lesion. Localization MRI is promising, but we still miss about 20% at least of index lesions. And then that initial trifecta that we talked about, cancer-free, asymptomatic, is not that great and not as good as surgery. And then there's no standards for post-ablation therapy, which is something we need to champion. And then there's also some concern over malignant potential Gleason Score 6. I'm not a pro at this, but this was a paper that looked at a patient who was treated with radical prostatectomy and pelvic lymph node dissection. His pathology at time of surgery showed that he had a 1 nodal met. He lived for 17 years. He received radiation therapy, chemotherapy, and androgen deprivation therapy, and he ultimately died of prostate cancer. They looked at the metastatic lesions from a genomic perspective and identified that the metastatic lesion was actually from a focus of Gleason 6 in the original specimen. So this is just some concern that maybe Gleason Score 6 might not necessarily be as indolent as we think it is. Future directions. I think there's a lot. Just touching on briefly, I think the precision medicine tests may play a role. Things like PHI, 4K, PCA3. This is PHI that just shows that with a low PHI score, you can use to predict a low risk Gleason score greater than or equal to 7. This is 4K score, just showing that when you add this to normal clinical models, you increase the area under the curve for detecting overall risk for T3 disease or Gleason score 7. And then when you incorporate those with the PI-RADS, this was a great study that showed that when you look at that indeterminate, that hedge call, the PI-RADS 3, the use of PCA3 actually improved the predictive accuracy to about 92%. So incorporating these markers may help us as clinicians determine the risk for a PI-RADS lesion. Future directions, though, ultimately it is paramount that you have a collaborative, interdisciplinary approach to this. Without working, two departments together, we won't make strides and progress with this. We need to improve localization with different imaging techniques. I think it's important to try to incorporate these biomarkers to help risk stratify patients and potentially look at some genomic markers. And then I ultimately think that we can use this to help change that risk stratification of men who progress while on active surveillance and prevent them from needing to undergo surgery or radiation therapy. And then education is also important. I think it's important to educate everyone who's interested with this about the imaging and the biology of the disease, so then we can bring this surgery to the OR, to the IR suite. I've been training for a long time, so there are a lot of people to thank. But it takes a village to raise a family. I guess it takes a lot of people to raise a guy for 12 years. So just a shout out to them. Thank you very much.